Good afternoon, everyone. I'm Mark McClellan, Director of the Duke-Margolis Institute for Health Policy, and I want to thank you for joining us today for this important and timely discussion. Duke-Margolis is committed to advancing practical, innovative, and evidence-based policy solutions. And right now, the health policy landscape is certainly evolving with an understandable emphasis on both improving health, given the burden of preventable chronic disease, especially in lower income and underserved populations, and on reducing our very high healthcare costs. These are ongoing areas of work at Duke-Margolis, where our mission is about bringing together a wide range of perspectives and developing better evidence on critically important health policy reforms. North Carolina's Healthy Opportunities pilots began as a first of its kind test program, initially approved under the first Trump administration, the Trump 45 administration, to help address these goals. Too often, non-medical factors like lack of access to healthy foods or inability to get to an in-person appointment seem to stand in the way of disease prevention and better primary care. This pilot has aimed to develop the infrastructure needed to enable these kinds of non-medical factors to be addressed when they can help lower overall costs and improve health, and to learn how to deliver new types of services in ways that could avoid costly disease complications and hospital visits. And of course, along the way, to learn to make adjustments to become more effective and efficient in this health reform work. Now that the pilot program has been delivering services for over 3 years, early evidence shows that well-targeted approaches to addressing these non-medical drivers of poor health, like food and nutrition, housing, transportation, interpersonal violence, and serious adverse events like hurricanes or home loss that can disrupt children's and families' health and lives. These targeted interventions to address these factors can improve health outcomes and reduce medical spending and overall Medicaid spending. North Carolina's Healthy Opportunities pilot was based on ideas and testing approaches that earned it bipartisan support. Federal and state leaders from across the aisle aligned on shared goals of improving health outcomes while creating a more sustainable and cost-effective approach to Medicaid and healthcare. And now, as the Trump administration is developing its strategies to make America healthy again, programs like the pilots can provide evidence on ways to implement tools and reforms needed that create opportunities for people with limited means and resources to improve their health and well-being. This helps us address chronic disease complications. It helps us avoid unnecessary healthcare spending, and it helps us achieve the goal of better health and net healthcare spending reductions. Based on the evidence on health and spending impacts from the pilots, the Centers for Medicare and Medicaid Services recently granted approval for North Carolina to expand the pilots from the 3 predominantly rural regions of the state where they're currently being implemented to become available statewide. As North Carolina Medicaid works with its partners to determine opportunities and options for expansions, this presents an important time to reflect on what the pilot showed, the implications for scaling them in a way going forward that similarly achieves sustainability by reducing Medicaid spending associated with avoidable health complications. As many of you know, Duke-Margolis is also supporting a pilot program here in central North Carolina, Integrated Care for Kids, that was approved by CMS at the same time as the Healthy Opportunities pilot. This program is also showing some promising early results for helping pediatricians identify kids at high risk of poor health outcomes due to a range of non-medical factors, those kinds of adverse events I was describing earlier, and similarly intervene in ways that lead to demonstrable reductions in those risks. During today's event, our speakers will not just review the evidence from the program so far, but also importantly, share specific examples of how the data that's reflected in this evidence connects to North Carolinians and their communities, the health and economic impact of the Healthy Opportunities pilots in rural communities across North Carolina. We'll also discuss the future of the pilots and other efforts to reduce the current and future costs of Medicaid by finding effective ways to reduce health complications and the progression of chronic disease, and then implement those effectively. It's going to be about continued learning, building on what we've done so far. We'll also highlight opportunities for other states and federal policymakers to learn from North Carolina's approach and experience. Before we begin, I'd like to give a special thanks to the Kate B. Reynolds Charitable Trust for supporting this work. I'd also like to thank the Duke-Margolis team who organized this event, and of course, all of you who are participating with us in this collaboration, this ongoing collaboration to keep people healthy and reduce our healthcare spending. I'm now pleased to turn to North Carolina DHHS Secretary Dr. Dev Sangvi, whose priorities include ensuring that DHHS programs, such as these important pilots, are accessible, efficient, and effective. Secretary Sangvi will provide some additional opening remarks before we turn to our panel discussions. Now over to Dev.
Everyone, I'm Dr. Dev Sangvi, Secretary of the North Carolina Department of Health and Human Services. I'm honored to share this video message with you today and look forward to our work together in creating a healthier North Carolina for all. As we work to increase access to care, I'm excited to build on the already strong foundation of a first-of-its-kind innovative Healthy Opportunities pilots in North Carolina. Thanks to the foresight of the North Carolina lawmakers, our state has a fiscally responsible and tested pilot initiative that leverages our best-in-class Medicaid program and the power of local businesses and organizations to put people and communities on a path to greater independence. The pilots have been a life changer for thousands of families in North Carolina. Healthy Opportunities shows us that providing evidence-based support for housing, food, transportation, and safety builds healthier communities and drives down the cost of health care. Participants are seeing the health benefits with fewer emergency room visits and hospital stays, and the state is seeing more than $1,000 in annual health care cost savings per Healthy Opportunities enrollee. Essentially, Healthy Opportunities is proving what we have all known for so long: the most effective way to lower health care costs and create healthier communities is to reduce the need for medical care in the first place. As a physician, I've seen firsthand how factors outside the exam room greatly affect whole person health, as people need food, shelter, and safety to thrive. And when Hurricane Helene brought devastating damage to western North Carolina, Healthy Opportunity pilots in the region were a critical partner in helping people rebuild and recover. While the pilots currently operate in 3 regions of the state, our federal partners at the Centers for Medicaid and Medicare Services recognize the value in this innovative approach to care and have approved a new 1115 waiver that gives North Carolina the option to expand statewide. I look forward to working with our partners at the General Assembly on opportunities for expansion so more people are able to access the life-changing services this program offers. Thank you for the opportunity to be a part of this incredible work that improves the health and well-being of people in North Carolina.
And good afternoon, everyone. We're excited to see you all today. Thanks to Mark and to Secretary Sangvi for providing some important opening context for this webinar. My name is Rebecca Whitaker, and I am a research director at the Duke-Margolis Institute for Health Policy, focused on North Carolina's healthcare transformation. We're excited for today's timely conversation about drivers of health like safe housing, nutritious foods, and transportation during this time of a rapidly evolving policy landscape. A couple of quick housekeeping items. Zoom closed captioning is available using the CC button at the bottom of your screen. And this webinar will be recorded and posted to our website in the coming days. To level set briefly, the North Carolina Healthy Opportunities Pilots, or HOP, represent a groundbreaking program to invest in health instead of healthcare services in the North Carolina Medicaid program. This required setting up new infrastructure to link previously siloed systems of care. And after roughly 3 years of service delivery, the Healthy Opportunities pilots have already generated Medicaid cost savings for beneficiaries while also contributing to improved health and community resilience. The pilots currently operate in 3 predominantly rural regions of the state and provide 29 services to eligible Medicaid members across key domains such as housing, nutrition, transportation, and interpersonal violence. The pilots are organized around 3 network leads, 1 in each of the regions, who manage a network of community-based organizations. These organizations provide the services to eligible beneficiaries and invoice Medicaid health plans who use allocated Medicaid money to pay for these services. For today's event, we'll start with 2 panels of experts on the pilots who will speak to their experiences and the existing evidence, followed by a discussion with former Secretary Cody Kinsley and Henderson County Manager John Mitchell on implications for pilots moving forward and for other states looking to implement similar strategies in an effort to improve health and lower healthcare spending and invest in local communities. So to kick off our first panel, we're excited to have folks joining us from our western part of the state. We know that the Healthy Opportunities pilots have been important for families to manage everyday needs that impact their health, but the pilots became even more important after Hurricane Helene hit Western North Carolina in September of last year. Helene caused unprecedented and widespread destruction, especially from flooding and landslides. The natural disaster interrupted access to power, water, and connection to communication, destroyed homes and businesses, and access to transportation to the area. We'll now turn to 3 panelists from this part of the state to share their experiences with on-the-ground response to Helene and how the Healthy Opportunities pilots impacted their recovery efforts. First, I'm going to turn to Susan Mims, President and CEO of the Dogwood Health Trust. As you know, standing up a new program in a predominantly rural part of the state requires unique considerations for building networks and service delivery models when greater distances may separate people and services. So why did Dogwood choose to invest in establishing a network lead or community care hub in Western North Carolina, and what opportunities did you hope this program would present?
Thank you, Rebecca. It's a pleasure to be here with you today. As a private foundation with a sole purpose to improve the health and well-being of all people and communities in North Carolina's 18 most western counties and the Qualla boundary for the eastern band of the Cherokee people, helping to bring this pilot to Western North Carolina was a perfect fit for Dogwood Health Trust. We work with many partners to improve the conditions that lead to health, including addressing barriers to affordable housing, a good education, economic opportunities, and overall health and wellness. And I learned when I was a practicing pediatrician how the barriers to these basic needs and opportunities get in the way of people living their best and healthiest lives. When I discovered that one of my young patients wasn't brushing her teeth because there was no place to spit in the back of the station wagon where she and her mother were living, I realized that healthcare alone cannot solve these issues. So this public-private partnership to help build a system that links quality medical care with meeting the basic needs to address the root causes of ill health just made sense toward our collective goals. Dogwood committed $12 million to help catalyze the program in Western North Carolina. And we are just thrilled with the positive results that are happening, the growth in the program through Impact Health, the organization we seeded to help do this work that you'll hear about, and the connections across sectors that are happening between healthcare providers working with farmers and partners focused on economic development and housing. This is exactly what we hope for.
That's wonderful. And if you could really briefly share, Susan, sort of how the pilot's infrastructure was used in Hurricane Helene response and how services were provided to impacted Western North Carolinians.
Yeah, having this network, one of the unexpected and really beneficial aspects of having this type of network was that we were able to use this network during the devastation that Western North Carolina experienced. One role that philanthropy can play in a disaster is to help make resources quickly available to those who are most impacted. And to do this well, we did have to turn to established infrastructure with trusted partners. The HOP network through Impact Health served as one of these avenues. They were able to get funds to partner human service organizations to serve not only the Medicaid beneficiaries they usually serve, but also everyone. And it has been a really blessing to have those connections and support for a reason in such a challenging time.
And now I'm going to turn to Lori Stradley to pick up on that thread a little bit. So Lori is the Chief Executive Officer of Impact Health, one of the network leads in the Healthy Opportunities pilots. So Lori, as a network lead organization, you are tasked with developing and managing a regional network of community-based organizations to provide that set of Medicaid-approved non-medical services. And this is a huge paradigm shift for many community-based nonprofits becoming Medicaid enrolled providers, billing for services. And the types of organizations providing these services may look very different across rural communities. So can you speak to how you've approached both building and communicating with your network, including providing assistance and program improvement? And then, kind of how did that shape the way you activated Impact Health to respond to community needs in the aftermath of the hurricane?
Well, I really appreciate the opportunity to be here and talk about this. And I have to start by giving my thanks to the state leadership and the vision that they had in launching this approach, because it was very much an asset-based approach. We have phenomenal leaders all across the state who are already doing this social health work every day. Providing food and food boxes, connecting people to housing resources and transportation. And my friend and colleague, Philip Cooper here, will talk a little bit about that as well. So the first piece was connecting with folks who are already doing this work so that they wouldn't have to make mammoth shifts or really start from nothing. And so creating relationships across the region was really the first part of that, and bringing people in. We also try to operate this network in relationship. It's not just contracts and transactions. It's about sharing the load in Western North Carolina, recognizing who does one thing well, and that there's a peer group, another organization that does something else well. So our agencies don't have to be all things to all people, and they also don't have to worry that if they have a member who's receiving a food box but also needs transportation, that they have to be the solution. They have to figure it out. So we get to build these relationships across the region. And we're also working with some of the most creative folks you will ever meet. They know how to find a solution. And so introducing the processes that come along with effectively becoming a Medicaid provider were complicated, sometimes daunting, but these folks knew it was doable. And they made a commitment early on to learn how to operate with compliance and under financial restrictions, to be able to support the privacy demands that come along with a Medicaid program. And to help make those transitions, Impact Health has a team of really great people who have worked in community most of their careers to provide training, technical assistance, and to tap in the right expert at the right time. There's no way any one agency can know everything there is to know about making this work. And often that expertise lives within the network. So we can draw each other in to provide training and technical assistance. For example, everybody in this region that is a part of this network, we are also survivors of this terrible natural disaster. So building health and resilience within our own community of health leaders is a huge and important part. And Philip and his team, folks from Resources for Resilience, are all coming together to take care of each other right now. But once we started, to get through the hurricane with this group intact, we had an opportunity to do rapid response. And I would say I would highlight two levels. The first is that we were already under contract and in partnership and could vouch for the integrity, the skill, the stewardship of each of these agencies. So quickly passing funds to them that were basically unrestricted, you do what you need to do, was pretty easy because we trusted each other. We had contracts in place that would already support this work. We had a relationship with our trainers and technical assistance providers, and we could rapidly respond and push those funds out without worry, and knowing that they would go to the area of greatest need and serve this community quickly. The second was the people. Our members, our Medicaid members, are spread all across 18 counties. It's over 10,000 households. And so when all communication was lost in the heart of the storm, wellness checks became something that we were hearing about every day. You didn't know where folks were. The people who knew where these folks were are our HSOs. They were our partners. Philip and his team and leaders in community health workforce, they were able to get in touch with folks faster than anyone else could have. And so we were able to maintain relationship connection and provide the resources that folks needed at the right time.
Yeah, I really appreciate those points on both the rapid response, but also having the trusted relationships and sort of knowing where people are and how to find them in the aftermath of Helene, especially in light of all the transportation and communication challenges. And also your points, Lori, on identifying strengths and harnessing creativity among human service organizations or community-based organizations, and really focusing on how to leverage efficiencies in that space is really critical. But now coming to you, Philip Cooper, Chief Change Agent at Operation Gateway. I might start by asking you to tell us briefly a little bit about the work of your organization and how you've helped connect people to the Healthy Opportunities Pilot services in your community.
Oh, right on, right on. First off, thank you for having me. Gotta say God is good because we are resilient in the Appalachia. No storm formed against us shall prosper, is what I will say. At Operation Gateway, we are a reentry and recovery organization. So we specialize in working with people who are coming out of a storm anyway, whether it's, a substance use disorder or if they're returning home from incarceration. But we all know community leaders who are always in the community, you will do things outside of your job description, right? And so when the storm came up, we answered the call of whatever was needed in the community. So, we did work outside of just serving those who were in recovery from substance use disorder and mental health, and outside of those people who were just coming home from prison. But we were serving anybody that needed help. And so we worked closely with other community-based organizations. Some of the partners we work the closest with, United Way, ABCCM, Umoja, ABIPA, Impact Health has been instrumental. I heard Dr. Stradley say rapid funding, and that was a blessing for us because, like, as a community health worker, community organizing is what we do. Advocacy is one of our core values. And so when the storm had hit, right, there was a whole bunch of people from all over the nation. Oh my gosh, I took so many selfies. They were sending resources, truckloads of resources, and it got to the point to where people didn't know what to do with it. But the CHWs were able to come in, and then we could add some structure, some organizing. Jess from Read to Succeed and Michaela, they was helping organize the hot food because, like, everybody and their mama was cooking, just wanting to do good, just like devastated, like, how can we help? And the CHWs were able to step in, and with some of the rapid funding that we got, what we did, because there were people who got laid off, who lost jobs. And so we were able to help people with like some day labor, and they would come and help out in the gym because the volunteers would get tired. You can't volunteer for so much. And the demand on the supplies that was coming in, we would be able to provide people with day labor. But guess what else? While they was doing that day labor, carrying all of this water and doing this, that, and the third, they was also building community. And see, we almost forgot about the mental health component of Helene because we was working on the water and not wanting to drink the water, but people was like mentally just devastated. But people was in community, serving their community, and it was a beautiful thing that we had an opportunity to see.
Yeah, that's really wonderful stories to elevate in terms of how you can jump in and leverage those networks and relationships that you've built and sort of, taking the structure that Impact Health and the Healthy Opportunities pilots have provided and kind of understanding what services people needed most and how to plug in. So really, really appreciate those stories and elevating those experiences. So thank you so much to our first group of panelists here. Really appreciate your time. We've just heard stories of how a network of community-based organizations created to address drivers of health through an innovative Medicaid program has been leveraged for disaster response and recovery. So we're going to switch now to our next panel, where we'll hear more examples of how the Healthy Opportunities pilots are affecting people's health and local economies, even beyond the direct services that the Healthy Opportunities pilots provide. So our panelists will also call attention to where we need to learn more and help make an even bigger impact. So I'm going to ask our folks, Casey Strout and Wendy Giannini King and Seth Berkowitz and Amy Russell to come on and say hello. And first, I'm going to turn to Casey Strout, who is the Food Hub's Programs Coordinator at Feast Down East. Can you tell us a little bit more, Casey, about Feast Down East and how you're involved in the pilots in the Cape Fear region?
Yeah, absolutely. Thank you, Rebecca. Thank you so much for having me. So Feast Down East is a nonprofit based in Burgaw, North Carolina. We're about 40 minutes north of Wilmington, situated in the very rural part of the Cape Fear region. And at Feast Down East, our mission is to strengthen farming communities in southeastern NC and while increasing food access. And we do this through a number of programs. We have mobile markets, a Food RX voucher program, a community supported agriculture program, but most centrally, all of these programs go through our food hub. Our food hub does marketing, aggregation, and distribution for small to medium-sized farmers. And how it works is we call up around 30 to 35 farmers a week, ask what they have available, upload it onto a website for our customers to purchase. These customers include churches and agency partners, as well as grocers such as Whole Foods and a lot of the high-end restaurants in Wilmington, and of course, the hop agencies.
That's great, Keith. Thanks so much for that kind of overview. Kind of picking up on that a little bit and acknowledging the vibrant agricultural sector in North Carolina. We've heard that the Healthy Opportunities pilots has had a big impact on local farmers. So how have you, in your work with Feast Down East, seen the pilots impact local farming communities, both providing the food, but also the families then who are receiving those fresh the fresh produce from those farms?
Yeah, so Feast Down East is listed as a hop preferred vendor for the Cape Fear region, meaning that we're listed as someone they can purchase their food for their food box program through. And what this means is firsthand, I get to see the economic impact that this has on our farmers. By being a reliable market, these reoccurring purchases allow our farmers to scale up, crop plan, and grow their businesses. These hop agencies have spent thousands of dollars with our farmers over the past year, strengthening our local food system and growing our local food economy. And then more anecdotally, I don't get to see the boxes end up with the families, but I do work with the agency partners who distribute those boxes. And I know that it's a very far-reaching program. I talk with some of them, they drive more than 45 minutes to deliver one box. They're meeting people who are overlooked by other programs. And what's exciting about when these hop agencies choose to purchase local food is that the food is fresher and traveling shorter distances, making it more nutrient dense. The same food that's going into Whole Foods and these high-end restaurants are ending up in the boxes. Yep. So just to summarize, I feel like this has been a really impactful program from soil to plate, and we love when these agencies choose to support local farmers through initiatives like this.
Thank you, Casey. Really appreciate that point about, making sure folks who may be overlooked by other programs receive some of the healthy foods coming out of the local farms, and the short distance for transport, making them, as nutrient rich as possible. Next, I'm going to turn to Wendy Giannini King, who is the Risk Reduction Coordinator at the Wilmington Fire Department. So not too far down the road from Burgaw, as Casey was just illustrating. Wendy, you've seen some of the indirect impacts of the Healthy Opportunities pilots on your community in Wilmington. So I was wondering if you could talk a little bit about how you've seen the pilots help people live healthier and safer lives. And if you could give some examples of some of the emergency response requests that have been impacted by pilot services in your community.
Sure. Good afternoon, everyone. I'm Wendy from the Wilmington, North Carolina Fire Department. Pretty close to Burgaw and Feast Down East. Thank you for the good work you do. The emergency services here in Wilmington see translation from the Healthy Opportunities Program into reduced need for emergent calls. And that's not emergencies like car crashes or house fires. Those are the day-to-day calls that firefighters often pick up related to lift assists, or people trying to age in place, or even just like nutrient related, nutrition related calls for service. So we are big fans of the Healthy Opportunities Program because we see that when community members connect to HOP, they are getting ramps, and that's getting them outside, into the community, to the nutrition, to the socialization, to the doctor's appointments. Maybe they are benefiting from Feast Down East, which of course is making their bodies stronger and more able to, to do without slipping, falling, or even getting themselves back up after a fall. I have a great story to share about the benefit of the Healthy Opportunities Program. There is a resident that I have met. I went to her house to do some smoke alarms, so she didn't have an emergency need. But while I was there, she was describing to me how she connected with the Healthy Opportunities Program. And because she has access to the world now because of the work that they did in her home, she feels great. She's socializing, she's eating, she's bringing her friends with her. And I just found that the Healthy Opportunities Program in this one particular instance opened this residents' world. We're seeing lots of people that are aging in place, and that's not easy without resources and support. So when it comes to the Wilmington, North Carolina Fire Department, we're big fans of this program, and we hope that it lives long.
Absolutely. Yeah. Thank you, Wendy. And I think, talking about the addition of ramps to sort of help people connect to the world and to other resources in their community is a really good example. And especially in some of those places where folks may not own their home and they may need to make some adjustments like that. I don't know if you wanted to say anything about kind of the folks living in rental properties and
Sure, yeah. So I get the opportunity to speak with a lot of that are renting their homes, and the landlord may not want changes, understandably, to the home when it comes to getting accessibility issues kind of taken care of. So we look for solutions, and the Healthy Opportunities Program is often one that I'm able to refer, is often a place that I can turn to help a resident get what they need. In some cases, ramps can't be built, and in those cases, perhaps they can be rented, or even built with temporary lifespan in mind. And I can't say enough how much this and the root or the symptom of the root is being addressed by Healthy Opportunities.
Yeah, absolutely. And thank you for that additional context on sort of how it influences and eases accessibility for home modification regardless of ownership.
Thank you.
So, yeah, next I'm going to turn over to Seth Berkowitz, who is Associate Professor of Medicine at the UNC School of Medicine. Seth, you are leading the formal CMS evaluation of the Healthy Opportunities pilots, and Casey's and Wendy's stories really point to examples of how the pilots have enabled healthy lifestyles through prevention. Do you see these stories reflected in the data that you're looking at for the formal evaluation, and kind of where are you seeing evidence of the pilot's impacts on health outcomes and Medicaid spending, touching as well maybe on areas where the evidence is still emerging?
Yeah, thanks so much. As Rebecca mentioned, I'm Seth Berkowitz. I'm a primary care doctor at UNC Chapel Hill, and then also do work on the evaluation of the Healthy Opportunities pilots. And what we see in the evaluation really is the aggregation of all these individual stories that we're hearing about, and exactly what people have been talking about today. It is what is reflected in the data when we look at it from a big picture sense. As many people know, programs like HOP and any Medicaid program that's done under what's called 1115 waiver authority has to have a formal evaluation. It's a requirement that CMS mandates, and so we're doing that. And the evaluation here for HOP takes place in two main phases. There's an interim evaluation, which roughly covers the first half of the HOP program, so about the first year and a half or so, and then a summative evaluation that covers the entire initial demonstration period. And so we, in this past year, completed the interim evaluation. So again, that sort of first year and a half. And we basically found a lot to support exactly what people were hoping to see when our state legislators and our Department of Health and Human Services envisioned the HOP program. Basically, we thought HOP would work by addressing health-related social needs. Those would in turn improve health. That would lead to decreased need for expensive healthcare utilization, like emergency department visits or hospitalizations, and less need for that type of healthcare utilization would reduce healthcare spending. And that's sort of exactly what we found. We found that The program reduces health-related social needs, so we see less food insecurity, less housing instability, things like that when people participate in the program. From that, we see fewer emergency department visits as a likely result of that. And then when we look at the trends in spending, we see that there's a decreasing trend in spending once people have enrolled in the pilots relative to what we estimate would have happened in the absence of it. And just to clarify what's going on there a little bit, if you look at, all the spending both before and after people enroll, what we find is that the times that people are enrolling in the pilots are often times of crisis, and we can see their spending start to go up even a couple months before they even enroll in the pilots. Once the pilots start, their spending, is elevated. They're starting at a point in crisis, and we're adding pilot services, and so there's some spending related to that. But then when you follow people over time, we see those trends going back down. And if you follow people for about a year or so, by the second half of that year, we estimate that you're spending less per month than you would have been if you hadn't been if people had not been enrolled in the program. And so there really is a differential savings. It's also, I think, important to note that that is not a savings that comes from cutting people out of services or those kind of things, right? If you just said, well, people can't have health insurance anymore, yeah, they're not going to spend so much on healthcare, but that's not improving people's health. But in this case, people still have access to all the same healthcare they've had before. And so a change in spending, I think, is really a strong indicator that people's health is improving. And that's why we're seeing the need for healthcare spending go down.
Yeah, that's great. And just really briefly, if you could touch on, I think kind of picking up that point on kind of the trends over time and spending, but what do you know so far? What can you say about some of the mechanisms that are driving those savings in the pilots, and kind of where do we need additional research to kind of help define the evidence?
Yeah, it's a great question. So, with the interim evaluation, it is a relatively small, what we call in the research biz, a relatively small sample size. So, we only had the first 18, 19 months of participation. And so what we do know is sort of big picture trends. So we know that we see changes in healthcare spending sort of across all the different groups that were enrolled in the pilots. When you look and break it down by pregnant individuals, by adults, by children, we see that there are decreases in spending across all those groups. So it's not concentrated in any one group. And so that is good. We also did not see big differences by region. So we know HOP is in 3 different regions, but when we looked to see if there was variation by region, there was not. It was all about the same. So that was all good. We don't yet know things like, are there certain clinical conditions that are associated with more or less spending? So, for example, do people with diabetes particularly benefit, or do children with developmental disabilities particularly benefit, those kinds of things? We don't have the sample size to have dived down to that part yet. We are planning such analyses as part of the summative evaluation, which will be releasing our report to CMS about a year from now. So stuff like that is in the works, but big picture, I think the main takeaway is that the HOP seems to be working broadly, so across a number of different population categories, however you define that.
That's great. I appreciate the additional context and thinking about lessons for effective implementation across the state. So looking forward to seeing that next round of research come out. Last but certainly not least, over to Amy Russell, who is the Chief Medical and Population Health Officer with the Mountain Area Health Education Center and the Impact Primary Care Network. Amy, Seth was noting some of the health impacts of the pilots on Medicaid beneficiaries. In your role, you're also seeing this from the perspective of healthcare providers. And so I wonder if you could speak a little bit to, in your role at the Mountain Area Health Education Center, what types of impacts have you seen the pilots have on the healthcare system and on healthcare providers in interacting with their patients?
I really appreciate that you asked this question, because we think a lot about the impact of this pilot on the community and on patients, but it also has a really meaningful impact on providers. And that's a really critical piece to this puzzle. So much of the work I do as a physician leader is thinking about recruitment and retention. And at MAHEC, we're looking at how to bring workforce to all of the 18 counties in Western North Carolina. And that really requires that we have great jobs and great experience in the workplace. And so much of what we know causes burnout in the medical profession is that lack of feeling of efficacy. And so when you have patients who have lots of barriers to care and it's very difficult to address them, that causes a lot of stress. And so I personally, when I have a patient and I see them struggling with a respiratory illness and they end up in the emergency room multiple times. And then I can say, I think we need to look at your home and see if there's something that's causing, triggering your respiratory illness, and then we can actually address it. Then that is really, really satisfying. And I know both as a physician and then as a leader, I have experienced those benefits, and then other people tell me, the other physicians in our community tell me that this is something that's really meaningful to them and they care a lot about it. And what's unique about the HOP pilot is it addresses so many issues related to provider burnout, that idea of team-based care and having that care coordination and support, making your workflow more efficient, as well as that social connection that's really important in overcoming some of the challenges that people have with burnout.
Yeah, absolutely. And you all are thinking very innovatively about how to enable this and kind of the integration with health and social care with the Impact Primary Care Network that just launched in the western part of the state. So in 20 seconds, like if you could share a little bit about how this could be available for other regions in North Carolina.
Sure. There's a group of primary care practices in Western North Carolina that's very dedicated to improving quality and cost. And they have decided to work together in collaboration with Impact Health to integrate social and healthcare, really to move this forward beyond the Medicaid population and to try to provide these services more broadly. And so that speaks to the importance from the provider perspective. We really see it adds value, and it's going to help us succeed in value-based care.
Absolutely. So lots to stay tuned for with Impact Primary Care Network, with the upcoming additional evaluation results. So thanks again to all of our panelists for a great discussion of the evidence from the pilots program so far, including the bright spots in the implementation that illustrates really how the evidence is connecting to North Carolinians and their communities. Duke-Margolis is currently developing a document that highlights some of the stories from North Carolinians who've been impacted by the Healthy Opportunities pilots. Many of these are drawn from our research on the program. And so we're going to post this on our website, and we'll share the link with you all when it becomes available. So stay tuned on that. I'm going to turn things over now to Rob Saunders, Senior Research Director at Duke-Margolis, to hone in on a discussion of what's next for the pilots and similar drivers of health programs.
Thanks, Rebecca. And really excited to hear the bright spots and the stories about what we know so far. And I want to turn things over to a discussion with two folks here that I have. Former North Carolina DHHS Secretary Cody Kinsley to talk about the next steps for North Carolina, and also John Mitchell, Henderson County Manager in the western part of the state. And really, I'd love for this conversation to build on what we've talked about so far and those bright spots and where we've seen the pilots working today, and to think about where we might want to go next a little bit. So maybe starting off to level set here, might start with you, John. Just would love to hear from your vantage point on where you've been involved with the pilots and their implementation and your particular part of the state, on where do you see the pilots working well, and maybe where do we still have work to do?
Well, that's a great question. And the first thing I want to do is just thank you for the opportunity to join this group, and particularly to participate with Secretary Kinsley, who's been a great friend to the mountains. And this program, of course, is a credit to him as well. So I'm not trying to build you up, Cody, but I felt I needed to say that when we got started. Good job, John. From our standpoint, I think you have to begin with a level set that, and you've heard this from the other panelists today, the county, particularly this one, was second largest in the West. It's the county's hospital. It's the county's EMS that are responding. The sheriff's deputies are encountering people in distress. Many of them have social determinants issues as well. The detention center is sometimes acting as a de facto behavioral health center. It's our DSS that gets involved as some of these determinants play out across time. But it's also, and I think you have to take that and kind of set it on one side, it's also the non-governmental organizations which the county supports and tries to build over time in a healthy community, which are responding and are part of of the Healthy Opportunities Pilot as entities which are performing these services. From my standpoint, you can look at it broadly across the board, or you could turn your attention to specific programs for which it's been useful. We could spend all day just talking about DSS, but I would just, to kind of place a light on something which I think has been growing across the state with the support of the Secretary and others, is our drug diversion court program, as particularly has used this Healthy Opportunities Pilot to help those folks who have become involved with our local law enforcement who are in the detention center, to give them the opportunity to avail themselves of some of the services which are now available under Medicaid, which have been talked about all through this panel. We've had a number of really good, strong examples of individuals who needed that extra help, either with housing or with transportation or with healthy food. And it's, you can't put your finger on anything in particular, but I think if you were to push me, I would say, yes, those are the things which are driving families to be reunited, individuals to become healthy, not just in body, but also practically involved in their communities. But as you can tell, Doctor, and Cody well knows, you give me the opportunity to talk, it's kind of hard to get me to stop. So I'll be quiet now and let this continue.
Thanks, John. And I think you do a nice job of highlighting both the practical implications that healthy opportunities can have, and the impact on people, such as helping them improve behavioral health and improving behavioral health care, and broader impacts on families in the community. Cody, maybe turn to you now. You helped oversee some of the earliest days of HOP implementation in the state, and help it mature from its initial days to the broader pilot. Would very much value your thinking on what we've learned and in terms of what's working well, especially that as we're at this moment where the state is weighing how to expand, where and how to expand the program, maybe potentially statewide, and where are there opportunities to really mature the program further?
Well, thanks so much, Rob, and great to be here. I'm always with my friend John. I prefer to be with him at Papa's and Beer, great restaurant in Hendersonville, but if it's got to be virtual, then this will work. John put his finger right on this. I think this is a fundamental piece of the design, which is this idea of being no wrong door, right? How do we build a platform that is accessible from a lot of different spaces? And so on one hand, the complexity of doing that and creating kind of a unified technology platform that makes that work, the process to kind of track and measure and do all of that, put dollars on top of it so there's clear accountability and accounting that make that work. That all kind of gets it really complex, but it's in balance with trying to make something that is elegant, that it lives up to the adage that everybody understands just kind of reasonably, which is that an ounce of prevention is worth a pound of cure. And we know the fundamental power of healthy food, giving people the tools they need to be healthy, and then in turn reducing the demand on the healthcare system. And getting that balance on the fulcrum right, the complexity necessary to do the tracking and ensure no wrong door while living up to that vision of simplicity and elegance. We learned a lot along the way. We learned really quickly that the capacity building dollars that we had to put out while trying to get folks enrolled, we had to strike the right balance, because we were spending a lot of money to get the system built. But of course, what we've seen in time with more people enrolled, now that the chassis is built, that the costs are being driven down marginally really rapidly. So great first lesson learned. We learned quickly that we wanted to give a whole lot of flexibility to our community partners and let them kind of figure out their own secret sauce. And we got a lot of feedback early on from a lot of community partners like, no, we need a little bit more prescription here. And so striking the balance on what that could look like so that they could play within the right rules of the road, but still modernize as they saw fit. As I think ahead, there's even more opportunity here to modernize even further. And I know we'll talk about that. What's exciting about North Carolina doing this is, we are leading the nation again in a pilot approved under President Trump's first administration, and getting support from the North Carolina General Assembly and doing this in a bipartisan way to really invest in the drivers of health to try to turn down, ratchet down chronic disease. So it's been a fun fail forward fast, if you will, where we've learned and been able to get to success really quickly.
And Cody, just to summarize two really important points that you raised there. One is that pilots are in the name of this program, and it's to be expected that we're going to learn as we go. And so at the beginning, there was some time that took us to learn how to deliver services, for instance, and you would expect that would become more efficient at that over time. And then I also really want to emphasize the point you make here on this is a bipartisan effort since the beginning. And I think that sort of tees us up to as we think about where expansion might happen, that we've got a strong base of support for the program because of that bipartisan nature. Let's talk a little bit about expanding and what advice you might have for others thinking about implementing either HOP or similar programs. And maybe John, starting with you, I know you spent a lot of time thinking about how to find service providers, how to live up to Cody's no wrong door vision here, say with community paramedics. Would love to hear what advice you might give to other county administrators across the state as they are thinking about implementing HOP or other similar programs.
Certainly. I think I want to touch on a couple of those programs that you just mentioned, but I think I need to start here. I've been studying Medicaid and Medicare and federal funding for different apparatuses that exist in the United States government for 20 years now. And sure, I can talk about them in an educated fashion. I've been in local government now for 10 years. And before that, I was in state and federal government. But it's easy for us as practitioners who are in this every day to forget that this country is run by volunteer citizens who, many of whom never really have kind of a deep dive into these programs. So the first thing I would say is that as we continue to grow these programs across the state, and as the state continues to expand them, the educational component of it with local and state and even federal leaders is going to be really, really important. It's a complex system. That's the first thing. So I just trying to package that in a way that makes it to where the people who are making policy decisions, local, state, and federal, so that they can see the benefit in it, which is evident from the data that you can see and evident from what the Secretary has just mentioned, is very important. Second to that, when I look down the road and I think about the big things, one of them is, and the Secretary alluded to this, we're really building this plane while we're taking it off. And so trying to find those organizations, non-governmental organizations, entities which can perform these services and do them in a way which is practical and successful is hard. Local governments and state do have the ability to kind of seed those things. A lot of the organizations which are listed as service providers here in the West already receive local dollars, and some include state dollars as well, but trying to work through growing those organizations, very important. I want to highlight just a couple of things you mentioned. Maybe, and most importantly, I think, is the community paramedic program. We've been working towards that here in this county for a couple of years. We intend to turn it on July 1st of this year as we move forward. But just for people on the call who are listening, what it is paramedics that work for the county that are out in the field when they arrive at a situation, an EMS call, perhaps it's a frequent flyer, it's an individual maybe who has a wound care issue, who may have issues being able to take their medicine in a way that leads to a healthy outcome. It's kind of a tip of the spear approach, as the Secretary was talking about before, kind of a no wrong door. But this is a front-facing by the county to have that interaction with individuals who are in need, who have social determinant issues. This has been going on throughout the state. Some of the most successful ones I can think about are in Macon County, McDowell County. Buncombe County has a very robust and successful one. If I were to make a pitch to the legislature now, I would say that those programs have shown a reduction in the amount of public money going out the door, which is exactly, I see no hand over there. They're quite right. Finding programs that work and copying them is probably the wisest thing that we can do as county administrators. I would also just a quick shout out, and I know there are people on the call that will agree with me on this. Our drug diversion court is saving the state of North Carolina about $1 million a year already. We've only been in operation for about 12 months. You can draw a direct line between keeping people out of prison and the amount of money that's being saved, both in Medicaid, social services, and it's returning families to being productive in society. So that may have been more than you wanted, Doctor, but those are just some, so for me, if this in the state, you could do community paramedics and the diversion court, you go a long way towards just kind of shoving off towards being able to utilize this in a very effective fashion.
And thanks, John. And I think those are great examples of success that you've been able to implement. And the more that we can see those success stories scaled statewide, especially as we start to potentially see healthy opportunities scaled, I think the better we'll be. Cody, going to turn to you probably for the last word. I suspect you have gotten phone calls from other states thinking about healthy opportunities and would definitely be interested in what advice you give for other states, as well as how to make sure that this type of effort is supported by others.
Well, I think North Carolina is in a position where, the question is, because of all the success we have had, how can North Carolina not afford to scale statewide, right? This is about, in the same spirit that John was outlining with similar upstream investments, we're seeing the returns on these in a variety of ways, and we can't wait. We've got to continue to push forward because we need to control costs of healthcare broadly, and upstream prevention is the clear answer. It's the win-win of driving down costs and improving health. And so a lot of other states are very interested and eager for this. We've seen states work to replicate North Carolina's program all across the country. And what's fun about the pilot environment is that we're continuing to learn from each other about, how to do this well. I think the two areas that I think continue to be opportunities for us to grow are, one, how do we get better about the data and the accounting piece, right? We've for decades worked to standardize healthcare billing and what that looks like and the information necessary to bill on healthcare, similar with what is standardized for a food box, what is standardized for a mattress, what is standardized, and how do we get those data into information flows such that we can make the administrative billing portions of this even simpler, and that's going to drive up the savings even further, take more friction out of the system for our administration side of this. I think the second area that's really promising is when we look at other programs, and I think particularly about John's experience on the ground, right? When you're trying to wrap programs like SNAP and WIC and the local food bank and other things around with healthy opportunities as a complement, really dovetailed into the medical system, how do we make sure that we're really taking advantage of what I think of as those low marginal cost programs to ensure that we're doing that first before then leaning into a higher marginal cost program? And that's not about making it more difficult for the folks on the ground. That's about us baking it in a way that makes more sense. And if we can get more people into SNAP and into WIC and making use of those foundational programs, we're going to drive that per member per month savings that Seth and his research has found up even higher. And so that's an even bigger opportunity for us as we scale statewide in North Carolina to learn that at a county by county basis, and as we look to other states as well.
Okay. Well, I want to thank John and Cody for taking the time today, and also want to thank everybody for joining. We look on the Duke-Margolis side. We look forward to continuing our research and contributing to the growing evidence on healthy opportunities. And also want to call out our funder for this work, the KP Reynolds Charitable Trust. we'll share more via our website and through social media and post our website in the chat. Some key things that I heard today are, the ability to leverage the Healthy Opportunities Pilot's infrastructure more broadly, especially in times of rapid response to natural disasters like Helene. The time it takes to build these networks of community-based organizations is non-trivial, but once we've been able to do that, you're really able to see some efficiencies happen, and be able to take advantage of the scale that's there. And also some of the indirect impacts of the pilots that we heard today, beyond just the services provided. And, we talked about behavioral health. We've talked about bringing families together. We've talked about reducing social isolation and investing in small and medium-sized farms, which we have a number of in North Carolina, and really thinking about how those cost efficiencies can grow as we expand further, hopefully to grow statewide and the like. So let me stop here. It's 3:30. Really appreciate everybody's taking the time today and look forward to continuing this good work together in the state.